Go ahead and record so that we can be able to share this again. And I'm going to go ahead and go on mute here, guys, and let you guys take over.
Perfect.
I'm here if you need me.
Awesome. Very good. Okay. I'm just finishing sharing everything. Very good. Okay. Well, thank you everybody for joining us today. Obviously, this is a very unique and anxious time for everyone. And I can't think of a community that is, having as much anxiety as parents and caregivers with children fighting right now, diagnosed with cancer, and survivors. And so, a huge thank you to Greg Aune, Dr. Greg Aune, for being willing to spend some time today and discuss some of these issues surrounding children with cancer and COVID-19. As I said, it's obviously a very anxious time, and Dr. Aune is very unique in terms of where he sits. He's not only a hematologist oncologist at the University of Texas Health San Antonio, but he's also a childhood cancer survivor himself, being diagnosed with Hodgkin's lymphoma at 16. And he's experienced quite a few late effects and negative effects from the treatments that he underwent. He's going to try and answer some questions and take people through some best practices and hopefully give some peace and calm to this tense situation. Thank you to Solving Kids Cancer and Donald Ludwinski. They had a webinar yesterday, and we've come together and worked with them to share their webinar. They're helping to promote ours, and we're going to hopefully work together on some others. The pediatric cancer community comes together like no other, and we have so many strengths working together. So it's an honor to work with everybody here. At the end, once we're through with questions, when we're through with the main part of the webinar, there's a Q&A button down below or a chat button down below. Please submit any questions that you have, and we'll try and get to them. I'll give you my email at the end as well. If we're unable to answer any, you can please feel free to shoot me a question, and I'll pass it on to Dr. Aune, or I'll get the answers for you. One final caveat, this is the lawyer in me. And allow me to introduce myself, which I didn't. My name is Jonathan Agin. I'm the executive director of the Max Care Foundation. We are a childhood cancer organization that helps fund research, and we support families that are financially struggling when they have a child in active treatment. We help provide financial assistance to low-income military and first responder families all across the country. And we also are advocates as well, pushing for change in legislation to help children. One caveat here is none of this is meant to be medical advice. This is just simply a discussion to hopefully help people ease some anxieties and some best practices here. So if you do have any issue that you need medical advice on, please consult your child's caregiver or your caregiver, or take the steps to get in contact with them, even though I know that's very difficult. Without further ado, thanks again, Greg. We'll jump in here in a second, but appreciate you being on.
Yeah, thank you for I think giving me the opportunity to speak to everyone. Jonathan and I go, I guess, way back now. I think I met him in 2015 was when I met him, 2014 or 15, and so when I really started to, I think, do a lot with the advocacy community. And I don't know if we foresaw a day where we were going to have to be talking about this type of situation. But for me personally, I always get a lot of inspiration and motivation from the activities I do with advocates, mainly because I feel like we're all on the same page and all have one goal, and that's trying to get better outcomes for our childhood cancer patients, to have survivors that have healthier lives after they do get through this. And this is just another, bump in the road, I would say. I think we have to look at it that way. At some point down the road, we're going to be past this pandemic, and we're going to be back to doing, what we're all interested in, and that's that primary goal of advancing, research and care for childhood cancer patients. So today I just wanted to, hey, I think we all need to focus on that day. That's something to always keep in your mind, because I have to do this, I think, just to kind of get through, this interesting time. And I'll get into a little bit later about kind of some of the individual challenges I have, which I think would shed some light on the survivor population, because I think there are some special considerations that we need to make sure everybody is aware of. And kind of what I wanted to do with Jonathan today is just provide that reassurance. I don't want, I want people to go away with this, with kind of a hopeful outlook of where we're headed, and not focus so much on the negative. There's a lot of negative, it's out there, and we all worry. I'm not different than anybody else. My family's not different than anybody else. And that's normal. But I think it's also really important to kind of work to put that aside as best we can and focus on what we can do and what we can control. So that's hopefully what I hope we get across today.
And I think that's a great segue into the discussion. There is a lot of confusion out there, and people, I think, in our community, especially parents and caregivers with a child that's in active treatment right now, I can't imagine the stress and the uncertainty that they deal with. Certainly when my daughter was diagnosed and fighting, this was not anything that I had to consider. But for those out there today, can you talk a little bit about the risks associated with what they may encounter as their child is in treatment, and how can they be safely mitigated, if at all?
Yeah, I mean, I think the one thing I forgot to mention that I wanted to is I don't think this situation, if there's a community better prepared to deal with a difficult medical situation, I don't think I can find one that's better prepared than our community. Just because I think everybody on the call, whether you're a patient or a parent or a survivor, you've been through, or going through serious medical situations, so you understand, the gravity of what's happening. And I think in large part, know where to get information that's accurate. And I think when we talk about the COVID-19, I think it's important to think about the patient population in separate buckets. One is the active treatment, which you mentioned, but then the survivors as well. And there's important considerations for both. Obviously, if your child is undergoing active treatment, that is something that I think is going to heighten a lot of fears and concerns, and it should. I don't think it changes a lot of the general management of what we would do with a viral respiratory syndrome or a fever in our patients. There's a lot of considerations in how do we protect the population, but how we actually manage a patient that has a fever and may have COVID-19 is not going to be markedly different than if they had flu, for example, other than we have to be really careful in isolating them from the rest of the patients in the hospital and in our clinics. And so one of the things that, the number one take home point from today is, if there's a situation you're worried about, you think you as a survivor or your child might have been exposed to COVID-19, your first call should be to your established oncology providers, whether that is active treatment and you have a team that takes care of you, excuse me, or you're a survivor and you have a survivorship clinic that you're associated with. Because the primary way that we have to deal with this is making sure that we don't bring patients into the area that may be under suspicion of having COVID-19 and then spread it to others. So it's not only protecting you, but it's actually protecting the other immunocompromised patients that we may have in the clinic. And keep in mind, whether or not a survivor, depending on where they are from completing their treatment, is actually immunocompromised, I think that's a consideration that might be open for debate. Meaning there is, I wouldn't go out on, and be really super definitive and say that someone that's 5 years off therapy absolutely has a normal immune system. I don't know if we know the answer to that question. We can't say the opposite. We can't say for sure they're immunocompromised, but just keep in mind, you have to be really careful if you're a survivor and understanding what is your overall medical situation and what kinds of medical problems may you have. So if you're someone that has heart and lung problems, diabetes, things like that, we know that increases, the risk of having a poor outcome and not having as good a trajectory if you get COVID-19. So that just, I think, stresses the importance of taking precautions to limit exposure. So, I think the good thing right now is a lot of this has been decided for us, meaning the leadership in state and local governments and federally has, put in place these social distancing measures. So hopefully that's going to reduce the chances of spread right now. I think as we get through this, as these situations start to be relaxed, then I think we're going to enter a new phase where you have to really consider, what are you doing? Who's coming to your house? what are you getting potentially exposed to? And I think the other thing is just in minimizing risk. It's all the same things that you've probably heard on, the TV and elsewhere. It's just washing hands, don't touch your face, being cognizant of, who you're coming into contact with, wiping down frequently used surfaces, like cell phones, counters, things like that, because the virus can live for a period of time in droplets on these surfaces, and you could potentially infect yourself. So that's kind of a starting point. I think that just to remember, you got to call your medical team is the first call, so that, and every institution across the country that takes care of patients has put in place a process for how they're going to manage COVID-19 risk and infection. There's some broad things that I mentioned, but I think every institution has specific challenges that they may or may not have to deal with. So it's going to be a little bit different depending on your institution and how your, oncology system works, because we're not all the same. But there are some general principles that we can all adhere to.
And that's a good segue into one of my next questions for you. But before moving on, what you said in the beginning about parents of children that are in active treatment and survivors, that, we shouldn't be thinking of it as really putting into place these extraordinary precautions above and beyond what families are already doing. With that said, obviously, we're supposed to be sheltering in place and staying in and not going anywhere and not exposing ourselves to people. So that's obviously different, but hopefully that gives some calm to people now in terms of not being so panicked if they adhere to the usual precautions and what we're supposed to be doing now.
Yeah, so, I think if we just think about it, normally what do we do? Number one, we're not going to stop life-saving chemotherapy treatments for someone that has cancer or a child that has cancer. We have to keep pushing forward regardless of what's happening with the pandemic. So that's number one. Number two, what do we normally do in those patients? We are, we look at their chemotherapy regimens, we look at when what their numbers look like, and then we tailor our recommendations on, what types of activities should they or should they not be doing based off of their risk of being immunocompromised. And at certain times that's, more acute than others. If you're, 10 to 14 days post really marrow-suppressive chemotherapy, that patient's going to be a lot more at risk of getting exposed to something and getting a fever and then getting admitted to the hospital. And in large part, I think a lot of, why we have those precautions in place is, getting a fever, it doesn't necessarily mean that there's a severe infection, but what it does mean is there could be, and there's a big enough risk when someone that's immunocompromised that has a fever that they could have a bacterial infection that we have to admit them to the hospital and treat them with antibiotics. So in the context of a pandemic, that's where you're, that's what we're trying to avoid, because we don't want, we want to minimize contact with the hospital as much as possible, because that, is going to be a higher risk area. If you're a parent or someone getting treatment, you have to consider, when your counts may be lower, you might be severely immunocompromised, and your medical team should be talking with you about that. You really, and this is no different than normal. Who's in your house, who's coming to see you. You don't want sick people around you. So if someone has a cough or a cold, you have to limit yourself. exposure to that person. And I think in the context of this, really infectious new virus that's out there, you have to consider, the people that are coming to the house, where have they been, and making sure that, before they come into your house, that they're washing hands and cleaning the surfaces and whatnot, because their, activities could potentially impact you. And so that's, one reason we social distance, limit groups, because you're just trying to limit your contact to numbers of people.
Yeah.
And for our immunocompromised patients, that's going to be more of a consideration, I would say.
Got it. Yeah, and that makes sense. I practice social distancing in general every single day, so But I'm glad to hear everything you just said, because I think hopefully we can create a sense of calm with that. I'm curious as to what instructions, if any, you may be receiving from your institution, from UP health systems, with respect to what you're telling patients and what you're telling your fellow care providers.
Right. I mean, the other thing to consider is the location of the clinic. So some places, and this is why you need to call your medical team, because some places will have hospital-based clinics and others may not. Our clinic in where I practice is actually a hospital-based clinic. So if we bring patients into our clinic, they're very near the hospital. And so now in the hospital, we're beginning to see COVID-19 patients. There's a specific area where those patients are going to be cared for, both in the pediatric setting and the adult setting. And so that's also one reason that we want to be careful about how we manage, patient calls and what we do with those patients. If a patient is, on chemotherapy and has a fever, they have to come in. So the kind of, we've given that advice, nothing has changed in the way we're going to manage fever and neutropenia, for example. However, when they get to the clinic, we've already developed a system where patients that have fever or potentially could be COVID-19 positive are, taken through a different route in clinic to separate them from the rest of the population, just to be extra careful.
Got it. Okay. And are you aware whether or not those are the same precautions being taken at other institutions?
I'm not aware of that. I think in general, so I'm going to talk about these a little bit, but the Children's Oncology Group has issued, I think, a couple really nice documents, one for survivors and one for patients under active therapy. And it's fairly general, but I know all of these institutions in COG have put in place, systems to deal with minimizing exposure risk to our patient population, whether it be survivors or active treatment patients.
Okay. Is that what you shared with me via email?
Yeah. And so these are, they're available in French, English, and Spanish. And there's one document for survivors and there's one document for patients under active therapy. And they're actually available on the survivorshipguidelines.org website is where you can find them. And then they went out to all COG institutions, I believe, yesterday, and institutions are encouraged to give these out to patients. So it's a way to supplement, I think, the specific site advice that places that we're giving. But it's really, I think, relevant to this discussion because it's not meant to be targeting just one institution. It's really general guidelines of what parents and patients need to be focused on.
Mm-hmm. And we'll make them available after the webinar as well for
Good,
people.
yeah.
We're getting a couple of questions, which is great. I love the engagement. When we're kind of through with the discussion, we're going to try and leave a little bit of time for Q&A. So please be patient. Appreciate it very much. So going back to something that you said earlier in this part of the discussion, from what you're aware of and from what you know, at least your institution, you're not hearing any interruptions to active treatment at this point, are you?
Nope, I haven't heard, any of that. The only thing I would say that I've seen that you could potentially call an interruption is bone marrow transplant programs that have decided to not transplant non-malignant diseases, meaning something they think they can pushed off for a while, that the risk to benefit ratio for those patients is better to hold off rather than start. But if it's a malignant condition, twice relapsed ALL, for example, they're not going to, withhold a transplant at this point in time. They're going to keep proceeding. And they're very well prepared for this type of situation because they're in hospital procedures and systems are such that they're meant to deal with, really immunocompromised patients and with, positive pressure rooms and et cetera. So.
Got it.
Yeah.
Okay. Okay. Well, that's good to know. And hopefully that continues, but more importantly for now, hopefully that provides a little bit of comfort for parents that are worried as to whether or not they're going to be able to continue to have their child treated and what procedures are put in place to help protect their child. So that's, I'm glad to hear that. There's a lot.
One thing I was going to say, Jonathan, is that we need to keep an eye on as an advocacy community is just what's happening with potential drug shortages. I know that there, it turns out a lot of our medicines, portions of them are manufactured in China. And so there's an ongoing, I think, watch to make sure that supply line is maintained. And so far, I don't think we've had anything come up, but that's something to just for everybody to keep an eye on. And then for us as advocates, if there's issues, if you hear that we need to get the word out to make sure that, this was an issue before this pandemic with drug shortages for certain pediatric cancer drugs. With, the vincristine shortage, last, I believe fall was, really was in the forefront. But, that could be something that might come up again because of this ongoing issue.
Yeah.
So just keep that in mind.
That was something that I was wondering about and had concern about as information and misinformation gets filtered out about, this drug potentially showing promise, this drug going to clinical trial to test and all of that, what potential impact it has on some of the therapies that might be used in our community. I haven't seen anything that would create an impact just yet, but it's always a concern of mine, and there's a lot of myths out there. There's a lot of misinformation. What are some of the myths that you can speak to, or some of the piece of information that you can help try and clarify? Should we take Advil? Should you give your child Advil? Should you not?
Yeah, I think this is it's a really sensitive area, and I think this is an area where I think we should be listening to medical experts and people that understand, how a drug gets approved. Thankfully, I think our community really understands clinical trials because most people, most of our patients and survivors have actually become familiar with how the process works. And so, some of the, I think, excitement over a medicine like hydroxychloroquine, while there may be a small study that showed some activity, I think it has to be tested in a scientifically valid way before we can truly say that it works. The downside to that situation is, because people are trying to get it, then people really use Plaquenil, which is the trade name for that drug, for autoimmune diseases, and now they're having a hard time getting the drug. So we want to be careful to not cause other problems. I think, I think our community actually has a role to educate others, just because I think by and large, we understand, how drugs are developed and how, how we develop a cancer drug. It's no different for developing a new treatment for a new virus. It's the same process. So you can't short circuit it and go into start giving things, ad hoc to patients, because you're not going to be able to know for sure, does it really work? Same thing for vaccines. There's a lot of, we need a vaccine for this thing, obviously, but it's going to take a lot of time, and vaccines are hard to create. There's liability associated with them. So that's something that everybody's going to worry about. And you can't speed up the process and come up with a vaccine and have it in 4 or 5 months. It's just not a realistic timeline. And hopefully we have one in 12 to 18 months. I know they're working on it pretty hard, and that's ultimately what's going to help. but I just think we have to be really careful in hearing, medical management, how, putting that into practice. So the Motrin issue, that's a good one. Number one, by and large, we don't recommend Motrin in our active treatment patients because most of them are going to have low platelets. So we just basically don't let them take it. And so some of you may remember that when you were going through treatment because it's a platelet inhibitor. If you have low platelets, you're going to bleed a lot more. And so we don't generally use Motrin. Whether or not that's actually, a true, kind of situation, I don't know. I mean, you can hear reports both ways. I think it just speaks to the fact that this is a new entity. And as it's, evolving in real time, we're learning more about what are the symptoms of the virus? How does it, impact certain populations? You may have read stuff about, that, it looks like that may be affecting young people in the United States more than it had in other locations. So these are all things that are evolving in real time. There was early on, I don't think people recognized that diarrhea could be a significant symptom, and now we kind of know that. So we're going to learn more, but I think it's just when you hear something, you should really, I think, focus on trying to validate that from the right sources. And not, Facebook is great, I think, for people to communicate, but it's probably not the best place to be sharing, the next best, way to manage, a new pandemic.
Yeah. Have you heard anything else that you would caution parents and caregivers on?
Yeah, I mean, the big ones I think were the Motrin and then, using, I know I've heard of people wanting to get hydroxychloroquine as a prophylactic treatment. Some of you may have heard of this unfortunate outcome in Arizona where someone took it and it can be a problem if it's not dosed correctly. So when it's given for malaria, I believe it's given once a week. In this situation, it's given differently, and we don't know if it works or not. So that's kind of the kind of the thing to keep in mind. Now, there are people using it, and I know they're working on trying to design the clinical trial to get that information, but that's going to take a while. So I wouldn't just go taking it. And the reality is you're going to have a hard time finding it anyway, because it's on backward everywhere from what I've heard. Yeah. Because it's been kind of a run on it. And we'll see where that goes. The other one that's out there is the treatment was, I think, hydroxychloroquine with azithromycin or Z-Pak.
Yeah.
So that's the other one that's kind of, under stress in terms of a shortage, which the problem with that is there's other, situations where we have to use azithromycin. So we, really don't want people trying to get that for unproven efficacy in a disease they may or may not get, versus like our sickle cell population, for example, when they get acute chest syndrome, azithromycin is one of the critical medicines that we give. So we need to maintain the supply for when it's really needed.
Yeah. And one of the things that I want to mention also is, in this community, we have a number of organizations out there that really bring us together and provide information and are working as fast as they can to provide as much information as possible, like doing a webinar like this, doing a webinar like Solving Kids Cancer had yesterday. CAC2, which is the Coalition Against Childhood Cancer, is an umbrella organization that has quite a few foundations and individual advocates involved. And, we as a community do try and protect our own and come together in times like this. So we're very fortunate to have these resources. So, as things evolve, keep checking in and checking back. Yeah. The survivor population, you talked about that a little bit, and obviously that, that's you're a survivor being diagnosed with Hodgkin's lymphoma at age 16. And you've had, I know, a lot of challenges your way. And when we first spoke about doing this, I heard you talking about the steps that you're taking. I guess, can you go a little bit deeper into, into what you're doing, what your concerns are, and best practices.
Sure. Yeah, I mean, I guess I'm an old survivor. I'm closer to 50 than I am 40 now. So, which is a good problem to have if you're a survivor. But it's, you know, I've had a lot of late effects, and I think the ones, if you look at the CDC, you know, kind of information, and I would probably say in January I started. It was probably February actually, because January this wasn't that out there yet. But in February I bookmarked the link on my computer, so I keep an eye on things, because in the back of my mind, I was starting to get a little worried, because this is something, like a bad flu is something I worry about in general. So I've had open heart surgery, so I don't have the greatest cardiovascular system, although it's adequate. And I got a fairly decent dose of radiation, and I took a drug called bleomycin, which some of you may be aware of, which can cause lung damage. And together they're, I think, particularly noxious on the lungs. So I've always had, you know, pulmonary fibrosis, and I've always had fairly significant deficits in my pulmonary function tests. And, you know, say being 50 to 60% of what would be normal for my age. And I've had, because of that, I've had 2 ICU admissions where I got, in one case, they thought I probably had the flu, and I ended up in the ICU for 2 weeks because of, you know, poor oxygen levels. And then another time I probably had strep pneumo, because I also don't have a spleen, and that actually impacts your ability to fight some of these bacterial infections. But the point is, I had these 2 really severe, you know, ICU admissions that were a little scary. And in fact, one of the admissions, I had a colleague who had a close friend that had survived Hodgkin's just like me, and that she went into the hospital at the same time in another city with similar symptoms. And when I got out of the hospital, went back to work, I asked my colleague, "Hey, what happened to your friend?" She goes, "She died." So, you know, that always has kind of been in my mind when these situations happen. So with that kind of context, or that, you know, medical situation, you know, of mine, I started thinking a lot about this, you know, not trying to be overwhelmed with it, because I think there's a point to where it can be super counterproductive, and you got to live your life. And that's something that I think I've learned over 30 years. It's just, you can worry all the time. It's not going to change the fact that you had treatment with, you know, radiation and chemotherapy. You can't undo it. You have to learn how to manage kind of the hand you're dealt. And so, you know, I started thinking a lot. I also have my wife who's a doctor, and she got to the point where she's just basically, "You're out," which is already what I was what I was starting to think. So I think I actually talked with my my direct supervisor probably before this really took off, about, you know, canceling my some of my clinics in March, because I kind of foresee this becoming an issue. And for me, I'm fortunate because I do a lot of research, so it's not like I don't have stuff to do. So I was able to. I'm not a primarily a clinician. I only do about 20% clinical time. So I would say I did my last clinic, and then since then I pretty much haven't left the house. I don't go to the grocery store. I've gone, but my wife has gone in and got stuff and come out. I don't go in. I went and got gas once. I was super careful about cleaning off my hands when I got done. You know, my kids they're not in school like everybody else. So like right now, they're not a vector. You just have to be, you know, aware of who is coming and going from your house. And I think this is not so much of an issue now as it will be, you know, in, you know, say 4 to 6 weeks, when we kind of start having a more normal existence, and that we're allowed to get out more. Then I think we're going to have to really think about those type of things as you know, as survivors, as patients under treatment, just because then, you know, there's more opportunity to come into contact with people that may, you know, be carrying the virus and not know it, because clearly that's some of what's going on. So that's kind of my perspective. You know, I think I just, you know, I don't want to find out what would happen if I got COVID-19, I guess is the way I think about it. You know, there's part of me that's like, I don't know if I can truly avoid it, because this might be a 12 to 18 month situation where we're going to be dealing with this. And can I really, you know, avoid, you know, getting infected over that entire time? so we'll just have to see. Right now I got to take, continue to take precautions as much as I can. My wife comes home from the hospital. I mean, she's out in the middle of it, so she's pretty careful about, taking off all her clothes and leaving shoes out in the garage and all that stuff before she comes in, because you just can't take any risks. But, I think the social distancing measures are put in place to protect people like me and all of you out there. So right now, I think we're okay, is what I would say. I think we have to pay close attention to what happens in the coming weeks as things get relaxed, and just be, very careful. Like, for example, I didn't go to church probably 2 weeks before there was any recommendation to not do that, just because I didn't think it was a good idea. I didn't know. I mean, Seattle had a ton of cases.
Right.
It was starting to pop up everywhere else, and I'm just like, I don't think we're testing enough. I think I need to be careful. And so that, it's just one of the things, that I did. So I really wanted to go watch our high school basketball team play in the state tournament, and was like going to go, and then it's like, no, can't go. And then they ended up canceling it anyway. So, but it's just like large crowds are not a good place to be right now if you have, have some of these, medical conditions that put people at high risk. And it's not like there aren't people that are younger that are getting COVID and unfortunately dying. There was, it's happening. So, I mean, that should be in the back of your mind. Not something you go to bed thinking about every night, but it just should be, before you do something, we should think about the risks, which is a little bit different than, say 6 months ago. I don't know if I would have told you need to be thinking about risks of getting an infection or things like that. Cause it's just for survivors, and I'm speaking more about survivors. I want them to go on and live their life and not worry so much about the, the health effects they're dealing with, other than making sure they're managing them, living as healthy as they can, and talking about that once a year when they come into clinic, and just making sure we're aware of these things. We don't want it to become, something you perseverate on. This is a little different right now, I think. Some thought about it is important.
Yeah. So, I'm going to start asking some of the questions that we're getting from the audience members, but I think this is a good segue at this time to move into those. But I think that's an important point, and for parents of kids in active treatment now and survivors, it just staying on top of things, trying to find as accurate as the information can be, trying to get your hands on it, trying to look at sources like, the foundations like Max Cure Foundation, Solving Kids Cancer, CAC2, Children's Oncology Group, that are trying to educate people as things keep changing. I think that's critical. And obviously the work that you're doing, and, I can't thank you enough for helping out today. I'm glad to see some questions here, and we have one. My son is 2 years post-treatment for medulloblastoma brain tumor and doing great. He was scheduled this past Monday for his 3-month surveillance MRI, and with our physician team, decided to postpone 1 month. Our hospital is Sloan Kettering in New York City, and we know the cases of the virus in New York have tripled in the last week. Is the risk of bringing him to the hospital larger than the risk of delaying a surveillance MRI? Should we plan to go in a month and just follow the precautions you mentioned? That's
that's a great question. I think to answer it is, if you look at it from a risk benefit ratio, I think, New York's a big hotspot, and I think your oncologists told you what the risk to benefit ratio was, and that they're worried enough about COVID right now that it's not worth doing a surveillance MRI. So in the meantime, just watching and staying in contact with them. So anything like vomiting or, any headaches, that would be an immediate call to them just to alert them, because in that situation, maybe the risk to benefit ratio isn't in line with delaying. The good thing is I think it's probably okay to wait a month is what I would say. But that is exactly the type of situation that we're having to deal with is measuring the risk of getting, COVID-19 versus, delaying, surveillance or therapy. That's right in the, that first year post treatment completion, which is, probably the toughest area to make decisions, I would say.
Yeah.
But you're at a great institution, and I know that they're making that decision based on what's happening in New York and not wanting to put you at undue risk.
And I will say that I know some of the folks in the brain tumor team there, and they're very responsive and always have been very responsive. And, look, you just have to advocate for your child.
Right.
And you are becoming a neuro-oncologist yourself. And, it used to drive me nuts looking at my daughter, wondering whether her eyes were inverting and what I was seeing. So,
Right.
You just be vigilant and watch what's happening and contact your providers. But I think that's sound advice on that. Another question here. My daughter's 3 years off treatment for T-cell ALL. Is she still considered to be high risk since she is still within the 5-year off treatment window?
Yeah, I think in terms of, I think what you mean is high risk for being immunocompromised, I guess would be the question. So,
I would think that, in the context of today's conversation, yeah, that is where that's going.
I think it depends. The short answer is no, I would say, in terms of being immunocompromised. That's the textbook answer, I think, based off of what we know about cancer treatments. But I would tell you, I think there's some evidence that the immune system is not quite that normal post completion of chemotherapy and radiation treatments. You could say that 3 years versus 10 years versus 20 years post treatment. I think there's evidence that it might not be completely normal. That being said, is it such a risk that you would totally isolate yourself? I would say no. What is more concerning for survivor populations is, whatever the slight risk is, or slight deficit in their immune system, plus having another type of health condition. So some of our older survivors that, may have had a lot of radiation to the chest, or, had, developed severe diabetes, have, got whole lung irradiation for, something like Wilms tumor, and have, bad lungs. Those are the patients that are in the survivor group that I think really need to be, careful. Everybody should be careful, but I think if you have end organ, deficits, heart and lung, you need to really be careful in the current situation.
Okay. There's a follow-up on that as well. So what precautions should they be taking with their child off treatment? And, if somebody in that child's position has an ANC that's just in the normal range, what does that say about the immune system's ability to fight off something like COVID?
If the ANC is normal and they're that far off treatment, I think I would qualify that as, or categorize that as, essentially having a normal immune system. That being said, I would still take the normal precautions that all of us should be taking. And in addition, maybe step it up a little bit and just be more aware. And I think by the nature of being a family that's gone through the roller coaster ride of being a leukemia patient, you're already doing that. Just because I think that's one of the outcomes from going through that type of situation is you're just going to be more vigilant, and that's fine. I think the trick is to not get so worried about it that it's consuming your life. And part of today, I think, is just to provide reassurance to people, because I do this too. It's like, I don't want to sit here and worry about what would happen if I get COVID-19. I don't want to find out. But there's some things I can do, to try to minimize my risk as best I can. And then try to focus on, doing whatever you can to, distract yourself from that. And it's a little hard right now because we're all cooped up and at home for the most part. but you just got to find that outlet as much as you can in terms of what you can do to, kind of occupy yourself and your kids and focus on, getting through this and not focus on the potential, bad outcomes that could happen because, and when we go through that as survivors, where you're worried about relapse, I would say it's not a lot different than that. That fades as people, think further away from finishing their treatment. But honestly, it really never goes away. I think for most patients, if they think about it, you're always going to worry about that, and you're going to worry about other stuff. This is just another thing that you got to put in there and be able to, be aware of what the risks are and then compartmentalize it in some respects.
Yeah. It's overwhelming, especially as we're all sitting at home and watching the news cycles and social
Right.
media and all that. So,
Right.
we are planning on doing another one of these webinars with a psychologist, a clinical psychologist, to talk about some of these issues.
Yeah, that'd be excellent. That's the other thing. I think if you talk with your institutions and where you're cared for, there may be a role for, we have a lot of child psychologists involved in pediatric oncology. That's one of the great things about our field. And I know that, there's probably efforts underway in being able to talk with patients. You don't have to be face-to-face in the same room. You could do this remotely via phone to provide reassurance and support. And so that's, honestly, I think that is a benefit that we have over some other patient populations because not everybody has access to child psychologists like that. Most places have, for childhood cancer, have dedicated child psychologists that work with us. I mean, where I work, we have two. And so they're available to help patients. And, what I would stress is I don't think any oncologist or survivorship doctor wants parents at home, patients at home worrying all the time about this. If there's something you're really worried about, give them a call. And I know that they'll, have ways of helping you, whether it be just, sometimes it's just talking with the doctor one-on-one can be helpful. If it's something that's more, involved in that, I think it's, you could, ask to maybe speak with one of the psychologists that they have at their disposal. I just, the wrong move is to think that there's nothing that can be done and don't call because there's too much going on. I think we want to help our patients is the reality.
And I will say, and we're getting a few more questions in, so I want to make sure I get to those too, but I'll say that, I've always found that clinicians in this community are so open to communicating with their families and with parents and caregivers. So, that's a great thing that I think you guys do so well. So a couple of questions here from our friend Donna Ludwinski from Solving Kids Cancer. Curious if there are any cautions in the short term regarding specific cancer treatments such as checkpoint inhibitors or anti-GD2 antibodies such as dinutuximab, since it caused capillary leak. And then there's a second question she asked: if children test negative for COVID-19 prior to cancer therapy, what is the risk of false negative?
Well, it's two questions. The first question, I don't know if there's a lot of specific information on checkpoint inhibitors or anti-GD2 dinutuximab. I think you're referring to, would you be more at risk to, have like ARDS if you had COVID-19? That's a good thought. And in fact, I've read a couple papers in the last few days that were suggesting one of the medicines we use for cytokine storm with CAR T cells, which is an anti-IL-6 medication, may actually be beneficial in patients that have ARDS with COVID. So it's in some respects, the bad outcomes are really kind of an overactive immune response to the virus is one way you can kind of characterize it, which is very similar to what happens with CAR T cells when they get that cytokine storm. The testing question is a good one. I wish we had an answer. I don't think we've done enough testing anywhere, and especially in the United States, to know. And what was your question? If you tested negative, are you truly negative? You know, we don't know
yeah.
we don't know what the false negative rate is. The reality is it should be low. It's a standard PCR based test. So if it's done right, the false negative rate should be really low. That being said, each individual test has to be looked at on its individual merits to calculate that type of information. And so we just haven't done enough of it to know that will be coming out, I would presume. And then the next, several months, we'll know more about that.
Yeah. Two more questions here. So this is probably something that whoever asks this on our Facebook Live hopefully is in contact with their caregiver. But the question is, would this be a time to consider dropping the 3rd year of LTM for our boy who is HR B-cell ALL, HR due to age only, diagnosis at age 11? I think that's something that they obviously.
Yeah, Jonathan, you're dead on. I mean, I think that's a conversation to have with your oncologist. The reality is maintenance. You just think about maintenance chemotherapy. Patients aren't super immunosuppressed. They're immunosuppressed, but not like they are during the first 6 months of therapy for ALL. That being said, the newer protocols are now for ALL have dropped that 3rd year for boys. And I know that institutions are going back and looking at their patients that, and so we've dropped it for new enrollees. And so now we're starting to go back and look at patients that were diagnosed in the last few years that are in the midst of therapy, whether or not we need to be doing that 3rd year for these boys. So that's a question for your provider, your oncologist, because they know the specifics of, the course and the disease. But that's a question I would ask them that, just straight up ask them.
Oh yeah, no, absolutely. And as we've been trying to say, a lot of this is being developed as we go along, but if there's any questions that are specific to your child, you got to get on top of that with their provider. Another question here, and we're getting close to wrap up time, but I want to make sure we get to everything. And if we don't, and people still have questions, I'll give my email at the end. But so here's a question from Facebook. The UK has recommended immunocompromised children and caregivers stay home for 12 weeks. Why is the US and/or COG not recommending it?
Yeah, that's an interesting question. So, I don't know at this point in time, I don't think that type of advice is going to come from our federal government, number one. Whether or not we recommend something like that as COG, I have not heard of that yet. But, I think that's just trying to, really take an extreme, viewpoint of how to protect oneself if you're in a high risk group. I would love it if we came out and said that, personally. I'm not, in the current environment and the way the United States is, kind of handling this pandemic, I'm not so sure you're going to get that type of advice or requirement. However, I think it's possible for individuals to look at the situation and, if able, to do that. No, everybody's going to be different. I think I would be able to do that considering my own life situation, but not everybody will, because you may have to go back to work, etc. So that's just something I think as advocates we can continue to stress, is like, who are we doing these social isolation measures for? It's for us. It's for our patients.
Yeah.
And, I think we have to just kind of continue to tell our stories, because people need to realize out there who are we trying to protect, and we're not kind of an expendable population. We matter too. So it was like in the early days of this pandemic, I read something, it was a survivor on Twitter that said, can you please stop talking about the people at risk are old people and those with underlying medical conditions, because you're making me nervous. Because everything was like that. So, don't worry about it. It's just old people and people with underlying medical conditions that are going to be affected. It's like, stop saying that. But yeah, I would love for us to put that type of recommendation out there. I wouldn't bake on it happening. I'm not aware of any discussions within COG of that either, but I can find out.
Yeah, no, and as things develop and, we see how things are going, I think it's just a matter of trying to stay on top of it in terms of gathering information that is credible, that is coming from sources that you can rely upon and trust. And at least within the childhood cancer community, the foundations are working overtime at this point to try and distill information and survive, frankly.
Right.
Nonprofits in this environment are struggling and are going to struggle. And, to the extent that organizations like CAC2 and Solving Kids Cancer and the Max Cure Foundation, and I've seen other organizations like Cure Childhood Cancer in Atlanta and Alex Lemonade Stand, we're all in this together trying to figure out how to best advise our community, and it's a stressful time, and the more that we can do to help calm people, I hope that people have a little bit more of a sense of calm today. And I think, the nugget that I'll take away from this conversation up front is, look, for parents and caregivers with a child in active treatment right now, aside from staying home and limiting the people that you're interacting with, you're really not doing anything different than you would be doing on a normal basis. And I've got a friend right now who is the sports information director at John Carroll University, and they've supported Max Cure Foundation for years now. That's my alma mater, and he's fighting multiple myeloma, and he's gone through one relapse, and he's gone through a number of different treatments, and he just was in for his second 98-hour blast of chemotherapy. And he was blogging and doing video blogs from there. And, a point that's really stuck with me is that what he's experiencing, the isolation and nobody visiting him, nobody being able to visit him, being alone for 98 hours is, now we're all getting a taste of that. So if we can all come together now and manage this, that's the important part. So as I wrap up, I just want you to leave the community with one final thought, and then I'll wrap up after that. But really, thank you.
Yeah, for me, Jonathan, what I would say is, I just think, our community is prepared to go through something like this because everybody, has, suffered through being a parent or a patient and understands what a serious medical situation is about, and gone through kind of the roller coaster ride of being, in the cancer community. So if any group of people are prepared to go through this, it's us. That being said, hopefully everybody learned something from those experiences and can use them going forward. But I just, I just think, focus on that, focus on the future, that this will pass, and, we're going to get through this. And there's a lot of people out there, doctors, nurses, psychologists, et cetera, that are there to help our patients. And that's something you have to remember. Just because we're in the middle of a pandemic doesn't mean we're going to stop the normal, process by which we, care for our patients. That's what we're here for. And, that's, you gotta focus on that, focus on the positive, as much as you can. And if you have questions, call your provider. I think, they're there to talk to you. We're going to ride this out, and we're going to be back here in the future talking about, other issues and how we're going to improve, outcomes for our patients and back to the normal stuff that we do. So we don't get anywhere by worrying about something we can't control, some outcome. If that happens, God forbid, hopefully, come out on the other end with a good outcome. But it's just like relapse, or getting a second cancer. You can sit there and worry about it all day, all night. And, I've done it. But it's simply not going to change, the fact that that's something that you're always going to be worried about. So, as much as we can compartmentalize, this is no different. It's just particularly, kind of something that's out in the open, it's harder to get away from because of everything that's going on. It's so much in the news, obviously. So, but I'm confident that, everybody here is going to do well. And I encourage you to, I mean, these are a lot of the really engaged, people in the community. Talk to the people at, other, families and patients at your institutions to, provide support, because that's another role we have, is we can support each other. So
Yeah, absolutely.
I just think, and this is, again, it's a good outlet. I've really enjoyed getting a chance to talk today, because I think sometimes as a survivor, it's just good to, get your thoughts out there in a venue where most of the other individuals probably see the world the way you do in terms of what their life experiences have been. That last question, I would say, I could sense the frustration and anger. I've been angry with a lot of the stuff I see too. Like, why are we not taking this more seriously? So the way you combat that is just being as vocal as you can about, why we're doing, what we're doing as countries and nations, and who we're trying to protect, because it's not just, grandmas and grandpas, it's, patients like survivors and kids that are in the midst of going through treatment, and cancer doesn't stop. And we've had several new diagnoses in the last, couple of weeks in the midst of all this, and patients on dialysis and et cetera with new diagnosis of cancer. We got to keep doing what we're doing, because there's going to be more patients. And that's, our community has to look at this the same way. We got to keep doing what we're doing, because this isn't, the root reason of why we're here didn't go away. It's just kind of gotten, pushed to the side a little bit, and we got to fight to make sure that it doesn't get pushed to the side permanently. So, and
we've always done that as a community. This community has had more than its fair share of adversity tossed in our way. It's a community filled with amazing individuals and great organizations, and we're fortunate to have folks like yourself that are so open and willing, and collaboration is what really is critical at this point in time for us all to come together. If you want to learn more about the Max Cure Foundation or any of the information that we're putting out today, you can go to www.maxcure.org. We are funding research. We're also supporting families right now that are struggling financially as a result of not being able to work, of people being laid off. And it's hitting all of us tremendously. And so, learn more about our programs, please visit our website, spread the word as to what all these organizations are doing out there. And, Greg, thank you so much for coming on today. Let me just say put the caveat back up there. None of this is meant for medical advice. Talk to your doctor, please. Greg, we need you. So stay isolated, stay safe. And
that's my goal.
Thank you.
I think down the road,
here with you again in DC at some point. So
I hope so. But I was gonna say, Jonathan, is if in 6 to 8 weeks, 10 weeks, if we think there's a need to do another one of these, I'm happy to do it, just to keep updates and everybody kind of engaged on what's happening as things transpire. So I would be happy to do that. I'm sure I'm probably going to be in my house at least through early May, it sounds like, because my kids' school is quarantined now. So I know my wife's not going to let me go out until the kids can go out. So that's the way it's going to be, which is probably safer. So
hopefully you're kept inside just enough.
Right.
We need you.
All right. Thank you. You too.
Everybody, thank you for joining us today. We're going to make this available, the recording. And if there are any other questions that you didn't get a chance to ask, you can email me at jonathan@maxcure.org. I think that's my email. I never really looked too closely at it, but I believe it's jonathan@maxcure.org. And I'll be happy to pass along any questions. Stay safe. We'll get through this. And again, thank you so much for your time and for the advice, and for hopefully adding a little bit of a calming voice.
Fantastic.
Okay.